All right, welcome to June's Roundtable for Integrated Care. Just some housekeeping stuff. This is a discussion, not a seminar. So it's an interactive format. So jump in at any point and add to the discussion. I'll also stop about halfway through and just see if we have any new information that you'd like to provide. We'll provide that space for you, but feel free to jump in at any point. You may turn on and off your own video and audio as needed. If there's background noise, we may mute you. So you can submit your thoughts via the question and answer chat if you prefer, rather than unmuting yourself. And we will be recording. So remember that this is also uploaded to a YouTube page. So anything you say, I want you to know that it will be out there for the public. And these are also our own views, not necessarily that represent MOPA's views. So it's my pleasure to kick off the event this afternoon. If everybody would introduce themselves, my name is Chelsea Gillum. I am the System Director of Adult Integration at Burrell Behavioral Health. Robin?
Hi, my name is Robin Lute, and I'm a psychologist at Compass Health.
Michaela?
Michaela Muehlbach, and I oversee our outpatient therapy department at Compass Health Network.
Kristen Thompson, I'm a psychologist and the System Director for Pediatric Integration at Burrell.
Wonderful. So this discussion also may contain some triggering information. We are going to mention body dysmorphia, suicide, and possible neglect. So I just want to give you those trigger warnings as well as we proceed. We are all integrated care specialists. We are not eating disorder specialists. But when you work in integrated care, you have to be a generalist, and that means knowing a little more than a little about a whole lot. Eating disorders are no exception to that. So we all agree that eating disorders should be treated by specialists. However, eating disorders are associated with serious health consequences, increased risk of mortality, and psychosocial impairment. Although individuals with eating disorders are likely to seek treatment in general medical settings, such as primary care, where integrated care clinicians are located, these conditions are often undetected by primary care providers. We want to talk about this today because integrated care clinicians in primary care settings are likely to see patients with eating disorders because of mental health conditions and comorbidities associated with these conditions. Further, due to our training in identifying risk factors associated with eating disorders and opportunities for collaboration with primary care providers, we are well positioned to improve the detection and management of eating disorders in primary care. We come into this discussion knowing that we have a lot to learn, but this is a little bit about what we know. And if you're interested in this becoming a broader discussion, let us know at the end and we'd be happy to provide that if possible. All right, and I think we're going to start a little bit with some of the research. Seems like a good place to start.
So I can jump in and get us started here. And I first want to acknowledge that there's really two different topics here. There's eating disorders and there's disordered eating. Eating disorders, disordered eating is the broader umbrella term that really refers to any kind of eating behaviors eating behaviors that are related to, Michaela, save me. Okay, I can define eating disorders and I'm doing a bad job at disordered eating.
That's okay. That's okay. I kind of think about like whatever the DSM says about eating disorders. Disordered eating is not to that degree or level. So someone who has disordered eating habits may have cut out a whole section of their food, like I won't eat any sugar. Disordered eating doesn't necessarily lead to the level of distress that one experiences for eating disorders or obsession. And there's typically not that kind of unrealistic view of themselves that we see with an eating disorder.
Thank you, Michaela. And I think understanding disordered eating and recognizing that that is an element of this is really particularly important in integrated care, because that's often what leads up to an eating disorder. And we have to be tuned into that and looking for that. Eating disorders are relatively uncommon. It's less than 1% for anorexia in the general population, about 1% for bulimia. But if you start looking at disordered eating, which is much harder to define, as you saw my inability to define it, estimates range from 5 to 80%, depending on what you're looking at and how you define it. But it's a much, much bigger issue. And we know in the integrated care settings, we routinely interact with patients who are on diets, who are or feel like they are over or underweight, who have destructive relationships with exercise, etc. And anytime we see any of those things, we need to lean in and figure out what's going on there. The other important thing to really acknowledge here with eating disorders is that although they may be, the base rate of them is low in the general population, anorexia in particular has the highest mortality rate of any behavioral health disorder. So anorexia, the mortality rate is 10%. And 1 in 5 of those deaths associated with anorexia is suicide. There's also a really high rate of self-harm. So among women who've been hospitalized with anorexia, there's one study that found that 36% of those women engaged in self-harm behaviors and 94% had some comorbid mental health disorder. So the associated risks with these eating disorders are really high. And the other thing just to note when we think about the statistics and the prevalence is that racially, there's not a huge difference overall between groups in terms of prevalence, but we do not have the same rates in treatment. So BIPOC groups by far have lower treatment rates than white individuals with eating disorders. So that's really where we see the disparity. Chelsea, that's my broad overview.
That's wonderful. That's a great way for us to get started. And I appreciate the definition of disordered eating and differentiating that from an eating disorder. Melkella, what are your thoughts right now?
I think it was a beautiful setup. I'm emphatically nodding. There's so much there that I think we could talk about, but a couple of the things that came to mind were when people do present in primary care, they will often present for physical health reasons. And so that's kind of the why behind this today. Like, what would be the purpose of us discussing this? Because oftentimes, as we're going to probably unfold naturally, talk about when is it appropriate for a referral to be made versus when is it appropriate for someone to kind of manage as a BHC in primary care. But people come to primary care all the time complaining, for example, of like lightheadedness or dizziness or sore throat, or they may present even to the dentist with kind of tooth decay or kind of a quickening of the erosion of the enamel on their teeth. And oftentimes we really look at these physical characteristics or physical symptoms, and we kind of get stuck in the physical symptoms and try to naturally like understand like why would someone have these physical issues and then they're not responsive to typical treatments. And it's typically in those cases that's something we want to start to, I like the way you said that, Chelsea, like lean in and learn a little bit more about that. And so yeah, I don't know, I'm thinking a lot about how it's going to present to our BHCs oftentimes as physical health. But on the other side of that, we don't want to over pathologize those types of presentations either. One thing that comes to my mind, for example, is that oftentimes people come in for physical health screens or physicals for sports when they're in high school, which is typically when we see eating disorders and disordered eating start. And those physicals for sports can often be the first time that someone may kind of start to present in ways that might suggest to their primary care provider that they are maybe flirting with some disordered eating habits, what we typically maybe even see in athletics in general, which such a focus on body and muscle and weight. So those are some of the main things that started off in my mind. This is my space, if you will. So the ladies know that I could go down rabbit trails really quickly and easily on this one. But that's basically where my brain went first off.
If I may, Michaela, I just wanted to add to what you're saying in terms of presentation and primary care. One of the forms of disordered eating is something known as diabulimia. And so you mentioned sports physicals or athletes or other sort of vulnerable populations potentially. And so knowing that individuals, particularly those with type 1 diabetes, also have this added risk factor. Not only are they dealing with a chronic disease every day that focuses specifically on numbers, A1C, food counting, sometimes the metabolic changes that go along with diabetes can contribute to weight changes, weight gain. There can be a perception that insulin itself makes an individual gain weight. And so diabulimia is not a recognized DSM condition, but it's certainly a term that's coined in the media and the literature, increasingly specifically meaning that a given individual will utilize their insulin, either restrict the amount of insulin they're using or avoid using their prescribed insulin altogether as a way to reduce weight. So that may be another area in primary care where we can just look for some red flags with people becoming maybe non-adherent to their prescribed regimen for diabetes as well.
Vulnerable populations, we treat a lot of geriatrics in internal med specifically, and disordered eating in geriatrics looks much different. Well, there's a lot of similarities, but there are some things that are really difficult, which is basically identifying it. And what we see is that medications cause a lot of dry mouth. We see individuals having difficulty swallowing, which will lead to disordered eating, loss of loved ones that they may have once eaten meals with. We see some taking back control with food, or attention-seeking behaviors, or you can kind of, if your caregivers are kind of trying to force food, it's a really good way to draw attention to the fact that you're unhappy. So there's a lot of behaviors, but also there's a lot of medical conditions that really lead to disordered eating in geriatrics. And it's really often missed. And part of that is because, and this is really sad, is that we tend to think that eating diminishes with age and weight diminishes with age. And that's just a normal part of aging. And that's not true. When you lose 5 to 10% of your body weight in a year, regardless of your age, there is a serious concern that should be raised. And then there's also this idea that a lot of individuals, geriatrics will stop eating to assist in suicide. And caregivers will also assist in that. Medical providers will turn a blind eye to that because in some ways they may think that they're helping them. Some ways they just don't want to address it, or that this is also a normal part of aging and their depression is justified or their feelings are justified. And so we really don't do a good job at identifying it in geriatrics and assessing for it. And so what I really want the BHCs to do in integrated care is to ask those questions because they're not being asked. Ask if they're having any trouble swallowing. Ask if they have a diminished taste and smell for food, and if that's impacting their weight. Talk to the caregivers and see if their kitchen's not being used. If they're also being secretive with food. There's lots of things where we can intervene and not necessarily treat the disordered eating specifically, but really identify what the underlying cause is and treat that. We can make huge differences, I believe, in internal med just by being present and making that part of our assessment.
Chelsea, when you mentioned the BHC role, there's a few other things that come to mind for me. I think that often as behavioral health consultants, part of our role is to provide psychoeducation to our practitioners, to our medical doctors, et cetera. And so you'd mentioned sometimes people not being comfortable with talking about certain behaviors or turning a blind eye. I think it is really important to recognize that there's a huge body of research that supports that physicians tend to either engage in some unintentional reinforcement of certain kinds of behaviors with patients. So maybe they'll see individuals who are rather thin, and it's always important to remember that thin does not equal healthy, right? So thin does not necessarily mean nutritious or strong or vibrant. And I think we'll probably dive into that a little bit more later on. That being said, it's very common in our culture, in our medical culture, to comment on somebody's weight when they are thin. And so we need to provide education about the unintended reinforcement for disordered eating that those kinds of compliments may provide. The other piece of that, in terms of turning a blind eye, again, Chelsea, do use your words, would be to look at providers' attitudes towards individuals who are overweight, obese. Sometimes there's a lot of discomfort in terms of just bringing that up with the patient, so that the provider may simply ignore it rather than viewing it as a very important part of overall health. And to kind of swing even in a different direction, providers will, again, unintentionally maybe shame individuals who are overweight and obese. So there's a huge body of research that talks about physician attitudes towards those who are overweight, and how maybe they don't necessarily receive the same attitude of compassion or understanding as other individuals, and or everything that patient presents with is sort of glommed under "you're overweight," so that the weight becomes kind of the main focus, and anything else that's complained about, pain, etc., becomes, well, if you would lose weight, you may not have that problem.
I think those are really valuable points, Robin, because we think about intention behind behavior is very important. And, losing weight is not, or gaining weight is not in and of itself good or bad. Sometimes the intention and understanding, and that's where I think the BHC kind of style or opportunity is so valuable, because we think a lot about the intention behind behavior in behavioral medicine. Like, that's what we do. And so, definitely there's a process wherein people will praise for losing weight, when in fact that person may be engaging in very unhealthy behaviors that could really spiral them into some damaging things. I mean, Kristen mentioned earlier the death rate, the mortality rate of people who have anorexia is high for a reason. They oftentimes, they don't necessarily starve to death. They die from complications related to other issues. They die of heart failure. They may die by suicide. And so there's just a lot of things that I think intention behind behavior is quite good and important to think about.
Well, and so I'll continue jumping in there until somebody cuts me off, I suppose. Of thinking about intentions behind behavior, Michaela, and that makes me think too of broader systems. So maybe we're talking about a dyad right now with a provider and a patient, or somebody that a family member that complements you. And so I think we need to also consider the broader system in which many habits of disordered eating develop, and what we can do to help that. So when we think about how systems, and in this case, I'm referring broadly to the family system, whatever that may look like in a given household, that systems tend to want to maintain homeostasis. And so if we sort of look at even a Bowenian type of family therapy, where or theory even, that, you know, the family system is an interdependent unit that will try to maintain homeostasis. Given individual may take on some of the emotions in the household, and do this through, express that through disordered eating and or eating disorders. So it's helpful to keep a few things in mind, that the system, per research, per what we know, really does make a difference. One of the things about disordered eating is that it's very multidimensional. There's a lot that goes into it. There's a belief that genetics, there's twin concordance studies that show that genetics play a pretty high role. I think specifically in anorexia, it's a little lower for bulimia, but that parents, mothers with eating disorders often have children who show disordered eating behavior. And within the family system, when an individual is demonstrating disordered eating, it will create chaos maybe at the dinner table, or again, unwanted types of attention or criticism or hostility that sort of seeks again to maintain the behavior. And so the one caution I do want to add is that we need to be very careful not to lay blame upon the parents or the family system itself, just remembering that symptoms don't develop in a vacuum. I guess that especially with disordered eating, it does happen within a systemic context. And so often, not only does the individual themselves require some kind of intervention or benefit from some help, the system itself, and again, there's even family-based therapy for eating disorders specifically that is evidence-based. So just keeping in mind, it's a pretty delicate balance between saying you're playing a role in the development and maintenance and then potentially healing of this behavior without also laying blame upon the system.
And I think, Robin, to expand on that, I mean, you said it's a delicate balance. And I think this is also one of the areas where ethical issues for the provider really come into play, particularly with kids, but with adults as well. You know, we've said that the family is part of the disordered behavior, whether, you know, it's like you said, it's not occurring in a vacuum. So are they included in treatment? What happens when that, you know, child or adult doesn't want the family included in treatment? Does that cause barriers to change because you're not able to modify the system? And then to take that a step further, when you're talking about a minor and they're engaging in pretty severely disordered eating, particularly with anorexia, at what point is this harm to self? And how do we toe that line? At what point are we aware of direct harm to themselves, and do we have to include the parent on that? And that gets really challenging. Take that a step further, say you've included the parent and you have a situation where you have a minor who is in need of compulsory medical treatment, which is an entirely different ethical issue, but you have a child who's in need of medical treatment, maybe inpatient hospitalization for an inpatient or for weight. And then you have a parent who says, no, I don't think so, that's not necessary. Well, then are you in a sort of weird murky zone where the parent is really enabling the disordered eating and is also in a gray area of medical neglect? These are all issues that we are going to see as BHCs because these are really happening in the healthcare spaces. It's the primary care physician that's dealing directly with the weight and the malnourishment, and they're the ones that are really going to be saying we need to hospitalize. And that's where a BHC may get brought in to deal with some of these complex systematic issues that deal with the families and neglect and enabling, and all of that becomes really gray ethically. So it is a challenging space to be in as a BHC.
Definitely.
The same goes for geriatrics too, Kristen, as you said that, it brought that to mind, in that when we look at the statistics for completion rates of silent suicide, which would be someone choosing to stop eating, it's almost 100% in the elderly that they are actually complete suicide, almost 100. In fact, the research will just refer to it as 100 because it's so close to being 100%. So violent means and eating, disordered eating purposefully to complete suicide, both nearly 100%. So, but it doesn't get treated that way. It gets treated as they're being stubborn or they're depressed. It's a serious issue. And it's just not treated that way. So also it brings in some kind of ethical thoughts and feelings within not only the providers themselves, but like our BHCs who are in those positions as well. When you have someone referring and not really treating this as serious as a condition as it actually is.
And then what do you do if you as the BHC or the outpatient therapist, but you as the behavioral health provider have gotten to the point where you recognize this really requires intervention at this point, a medical intervention beyond me? Are you violating privacy to raise that flag? And then you're getting into a space with the physicians. Well, and there's a third issue. Are you staying in your lane? You know, for all of us as behavioral health providers, it is really important that we stay within our own, you know, zones of competency. And if we start saying to a physician or medical partner, this person's really dangerously malnourished, I think we need to look at that. Yes, we can say that, and we should be saying that, but how much more can we say? And you know, Michaela may run into this more than I do because this is something she's really knowledgeable about. I'd probably go, okay, I think there's a problem here. It's all you. A lot of physicians don't necessarily know what the next step is. And many providers who have developed some specialty in eating disorder areas maybe do. And so how do you provide that advice and some of that guidance about next steps to a medical colleague who maybe isn't as experienced? It gets really gray. And then you're in the zone of compulsory treatment where maybe you and or a medical provider are saying, you have to be hospitalized. You are dangerously unwell. Can we do that? Is that okay? Because when a patient engages in behavioral health care, they're in the driver's seat. And, you know, on rare occasion, do we ever take over, namely for inpatient hospitalization for suicidality? And how does this fit in that? If you are sort of quietly, passively harming yourself by not eating. So I think these are just really murky issues.
And I think one thing I want to point out as well related to types of kind of diversity space, maybe even privileges, that treatment for eating disorders is extremely expensive and that it is often not covered by insurance or it is not fully covered by insurance. There are a lot of wonderful places that allow for kind of self-pay options, which is wonderful. Like there's discounted, but we're still talking into the thousands of dollars per week. It is really expensive. Wonderful treatment, highly expensive, and sometimes that alone is a huge barrier to getting care, even though there is this mentality that anorexia, which oftentimes is the one that will often be hospitalized or sent away to treatment, that it only occurs in affluent white females, and that certainly is not the case. So I think there's, like all topics we cover, it is not by accident. There are so many layers that go along with it. But I think that's an important space to think about too, which makes it even more important and valuable for us as behavioral providers to identify and work towards intervention early to help, much like anything else, to help it from becoming a full-blown issue. And then the only other thing I was thinking of in this moment is this is a very messy topic. It's a very uncomfortable topic for many. It's truly like you think about primary care providers and nurses are used to seeing everything. Like the stuff that we may turn away from and disgust, they run towards. These types of behaviors, there are some, what some might describe as just outright disgusting kind of behaviors, but it is a function of the illness Nobody wants to do the things that happen. Like vomiting and laxatives are not pretty, they're not sexy. These are functions of the behavior. And it's a very, it's a tough topic to talk about. Those words alone are hard to say out loud anyway. And so I think that's another piece of really getting yourself comfortable as behavioral providers with saying those things, researching those things, and learning about the words and getting comfortable with them.
I think this is a good time also to open it up. If anybody has any thoughts, we brought up a lot of topics. We don't have all the answers. We would love to hear also your thoughts or input if anybody has any. I know Nancy says here, some advanced directives specify that person does not want fluids or food. Absolutely. So again, kind of that weird gray area that we're all kind of trying to manage ethically. Other thoughts from people who are on this roundtable discussion call?
Any questions or maybe a situation that has come up as a BHC that you would maybe like some input on for future? Hi, Sarah.
Hello.
Yeah.
I could give some info. I have a provider who often sees patients with eating disorders, and honestly, I'm not very comfortable. Usually what he wants me to do is just refer them on to a therapist that specializes in eating disorders, which I find very hard. The cost piece is what is usually the hardest thing for me. And I'm in Columbia. So I don't know. I just am looking for any kind of help, I guess, that I can maybe do in the clinic. If you guys have any suggestions, usually these patients are young adults. This provider has a lot of association with the athletes at Columbia College. So he gets a lot of referrals from there. So I kind of just am at a loss whenever I talk with them, because it is a very hard topic, and usually they're not really wanting to speak with me. And I don't know how he approaches it either. So that's another thing that I'm not so sure about. I came into the part where you guys were kind of talking about like what's our lane and what's theirs and stuff. One thing that has bothered me lately was weight checks. So I don't know what's right, what's wrong, how should those be done? But it has come up that it's concerning, and I don't even know who to turn to about that. So maybe some more info on that.
I love this question. I'm going to jump right in. I think there's a perfect opportunity here for us to talk about what is reasonable within primary care and what needs to go to specialty care. In primary care, I think if there are behavioral mod kind of things that maybe a person's kind of lean too deeply into some eating behaviors or exercise behaviors that are starting to become a little unhealthy or misguided, behavioral modification strategies often work really effectively. Replacement, focusing on healthy foods, healthy exercise, not stopping those behaviors, because the example of an athlete eating healthy and exercising and staying in training mode is very important. Their livelihood kind of depends on that, their scholarship for their school, etc. When we start to delve into the world of where it might be more of an eating disorder, where there is intense distress and obsession, and this eating behavior and exercising behavior has become the coping strategy, that is oftentimes more, we need to hand them off to a specialist or at least outpatient kind of intensive therapy services. because that is where you really start to have to peel back those layers that were mentioned before of family systems and what is the underlying fear and the unrealistic body image and kind of expectation or goal that's not going to be appropriate for primary care. And so, to your point, Sarah, you're right. I mean, having someone who specializes in eating disorders it's few and far between to find. And then of course the cost can be prohibitive, but those are some pretty basic things. And the only other thing I'd say about the weight check is oftentimes if that is a trigger point for individuals, we often would just ask them to turn around and not see what the weight is. Again, that's very case by case, because we don't want to withhold health information from our patients either. But we know that on our ethics code, it states that we must kind of use clinical judgment if something is going to be harmful to somebody. So that's a very small one-off, but that's an example of what can be done.
Sarah,
You know,
also, we recently had someone from our eating disorder clinic at Burrell come in and talk to our behavioral health consultants about how we can collaborate. And I thought that was really helpful because they were able to say, we can only provide so much treatment here. Then they usually go to their primary care doctor. And these are the things that they usually do wrong once they get there, like not doing blind weight checks, just doing a weight check where they can see their weight. And that might be a trigger point. The way discussions happen. And so we were able to say, how can we help you get them there and get the information you need to have them be successful in specialty treatment? And then how can we help while they're getting that, if it's outpatient, when they come into their primary care doctor? And how can we support that? And really creating that communication with a specialist. And then she was open to call me at any point, ask me questions with specific patients. So we were able to consult with her. So if you can find somebody that you can consult with also that's local, that's really helpful. And just kind of work in tandem with them. But also, Chuck asked here too, what do you target for treatment? I think Michaela was hitting on that. Behavior modification stuff is really a lot of what we target, but also that the family system dynamics that Robin mentioned, we can address some of the family system stuff that was within our control, whether it's geriatrics or it's regular population. That's a huge piece of this. We can also look at medications that are being prescribed. Of course, my focus has been on geriatrics for this, but some of those medications that cause a loss in taste and smell, we can identify those and bring it to the provider's attention. Can't change the prescription, but we can make suggestions in that regard. And then absolutely, you said related depression, anxiety, we can treat the underlying concern as well. That will help alleviate some of those behaviors if it's early on and we are able to catch it early on.
There is a screening tool called the EAT, and we will post some resources too near the end. Total sidebar, Sarah. I know that as a BHC, you're in and out of meetings and things like that. So, but this is my specialty area. So I am certainly open to you back channeling me. We can talk even more if you'd like. Sorry, Robin, I cut you off.
it's okay. I've had so many things that I'm enjoying this discussion coming and going. One of the things that popped up for me, Chuck asked it quite like literally at the same time I was thinking about it was, there is a fair amount of research that suggests, and Michaela, correct me if I'm wrong, please, that when we get to the eating disorder level, so to speak, that there's a potential that kind of behavior might be very similar to even obsessive compulsive type disorders. And so that makes me jump to medication in terms of what might we prescribe, not us, what might the team prescribe or suggest for OCD, and would that be helpful for a given patient or client that we're seeing? Also, the idea of just meeting with the client themselves and finding out, are they interested in making a change? So I've been in a a session previously as a behavioral health consultant in which a young male was coming in, always with his parents, that very typical pattern that we see with the system, where there's a lot of hovering, maybe a lot of heavy parenting, some enmeshment, and trying to break that down and see if the client themselves sees a problem and or has any desire to change. So are they in a pre-contemplation stage where they're not seeing this as an issue, and where do we start with that? Of course, psychoeducation, when somebody's in pre-contemplation, right? Or if they're in contemplation. And then, like I said, my thoughts are going everywhere, so I'm just throwing in a whole bunch of stuff. Sarah, I'm thinking back to some of your questions. I know several of us were former college athletes, and one of the things that comes to mind for me is I would venture a fair amount of money that my coaches in college were not educated on the topics that we're discussing now, in terms of their own behaviors and what they were reinforcing or not reinforcing, because of course, coaches get paid to win, right? That's how they maintain their job. So Sarah, I know this is a bold proposition, but I wonder about working with the coaches or the health department at the school, and again, providing some psychoeducation about the ways in which they may be actually hurting their athletes.
I think it's such an important topic that is often not discussed. Like, it hides in the shadows, and it's often how people who experience eating disorders feel. It's so, Robin, to your point, like, very obsessive compulsive, and it's also very similar to an addiction cycle. And it becomes, it's kind of the statement that I would hear often or use in my own kind of therapy with clients is, you start off by using this to control, and then it ends up controlling you. I mean, when it becomes a full-blown eating disorder, you are pretty much in the backseat at that point. So I could get so in depth, and as Chelsea mentioned, we want to know if this is something you guys want to know more about, because we can do more for this. We can do a CE presentation, we can do more. But just starting off, I think that there are pink flags and then there's red flags. I think the pink flags are, this person has started skipping meals, or they've started kind of using different reasons or excuses for why they are not doing things that they used to do. It's kind of like depression, right? Like, we see that with people who have depression or anxiety. Like, oh, I'm tired, I don't really want to go, when in fact it's like, that's really anxiety producing for me to do that. Then the red flags really start to become, this needs to be talked about very directly, and treatment needs to occur sooner rather than later. And that would be women missing periods because their body weight is so low. This would be them becoming lightheaded or passing out because they are not eating enough, or their metabolic system is so off because of the constant binging and purging behaviors we see. Or something we don't talk about a lot, I was thankful to see binge eating disorder made it to the DSM-5, but gaining weight at such an incredible rate that it becomes a health hazard, it becomes problematic. So those, I think, would be red flags that for me in a behavioral health area, I would want to, I would really suggest, like the pink into the red. And I think it's like anything else. When we start to see multiple things start to piece together, that becomes the clinical picture of intervention versus, oh, this person lost a little weight, or, oh, this person is exercising more. Those do not make an eating disorder. And so I just really want to throw that out there because I know this can be such a chasm of information and misinformation. And so I think it would be helpful to start looking in those spaces.
As you're saying that, and Michaela and Chelsea's adding some resources, I feel like we would be remiss in forgetting to mention that we did try to recruit or had the thought of bringing a dietitian to this discussion and just simply didn't have the time or the resources to do that. So for those of you that are working in an integrated space where the team includes more than just medical and behavioral health, it sounds like in some ways there's room potentially for lots of us to have that conversation with the medical side about even how do we want to approach this stuff, and what does it look like as we're talking about the pink flags, and how are we going to become more comfortable talking about weight as part of health, and what does that mean, and as Kristen had mentioned, staying in our lane, that makes me think, well, can we bring more cars into, or more lanes into this highway to health, right? That if we have nutritionists, dietitians, other specialty providers, if we have access to them, can we bring them into the discussion as well?
Yeah, and we need to, ideally all of this is multidisciplinary. Of course, that's our huge goal. But I was thinking about some of the interventions for the geriatric population. How do we make these changes? A lot of them require a dietitian, and making some suggestions on how to prepare food, how to make it more flavorful and things like that. That is not in our wheelhouse. But we can identify those issues and get them where they need to go. But we really need that team approach so we can get them where they need to go and know what we need to be asking. Because I'm afraid we're going to be the only ones asking those questions for a while.
And I completely agree. And I love this idea of supporting our primary care providers as well in, you're not wrong. It's just there is an art, right, to doing this. And so when I thought earlier about this being similar to an addiction, when we manage anxiety or depression with our patients in a behavioral health primary care overlap, we do it in a different way. Many times they are there because they are struggling, they need help. With eating disorders, we need to come at it in a different manner, or even disordered eating when it's gotten to the degree that it is becoming a coping strategy. That we can't kick the front door down, just like with addictions, and slap it out of their hand and say, you're not supposed to do this. They know. It's really more about like, okay, stages of change were mentioned earlier. Meet them where they're at. Education is important. Giving them the information is important of like, I'm a little concerned that your weight is now kind of dangerously low, but going in and saying you just need to eat, or you just need to stop eating. When it's a coping mechanism and strategy, that needs to be replaced with something else. So soapbox on that one for sure.
Actually, the research shows it worsens the condition.
Yes, it does. And all it does is make us go into the shadows more.
And with shadows, obviously, the prime thing that comes to mind for me is often the shame. Again,
Yes.
That there's a lot of part of what's hard to detect with disordered eating is that there's a lot of shame around the behaviors, and so they're hidden. And so people will, Michaela, you referenced part of this earlier, that they'll maybe start to take meals alone, or I'd mentioned diabulimia. People will stop stop their adhering to their, and we see their numbers go up, but like their A1C go up, and we don't necessarily know why, and maybe they don't feel comfortable being honest with us about why. And so in terms of not kicking down the door, some of the, again, systems dynamics that tend to maintain these kinds of behaviors are often those that are critical, and those that are hostile, and those that are overbearing. And so we need to know our own biases, help our providers, whoever they may be, talk about their thoughts, their biases, and really approach this with compassion and with a sense of calm, so that we're not recreating the very system in which a lot of the disordered eating happens. So we don't want to be critical.
Right.
We have a few more minutes. Any last thoughts from the individuals that are joining us?
The only other thing I want to add, while maybe others are typing or thinking, is the question was asked earlier, how do we start these conversations? I think that with any interaction with patients, we always want to ask, how can I help you? People will often say to us, like, I want to feel better. Well, then that's up to us to help them define that. What does that mean? How would that feel in our bodies? What would we be doing differently? That, I think, is going to be the space that you can start to work. And once that space starts to improve, we often find that the other does as well. So, for example, if someone is feeling very invisible in their family unit, maybe someone else gets a lot of attention, or maybe they're kind of all the resources go to their sibling. You may develop an eating disorder by starting early with getting attention by, having special meals prepared, or this, that, and the next. And then it starts to spiral and snowball into a full eating disorder. Well, what the underlying issue is feeling invisible. What are healthy mechanisms that we can work on to help you show up and be seen in your family unit? And when that starts to be repaired and worked on, there is no longer the need or the fear of losing control if I let go of this particular behavior. Very watered down, very oversimplified example, but finding out the why and the underlying thing is typically a good starting point. And it's non-threatening, because we're not telling them just to put this down. We're asking them to pick this other thing up.
Love that, Michaela.
One thing that's coming to mind, and I'm just putting this out here as a question, I don't necessarily have the answer. I do know that there's some research on it, but I'm not entirely familiar with it. I'm not well read in it. When we think about the US population, I mean, to some extent right now, we are talking maybe in terms of diversity, we're maybe talking about the United States on some level, given that we do have an abundance of food. We don't see eating disorders or disordered eating quite as much in countries where there's less food available, right? In those cultures, being a little bit overweight even would indicate a more preferable state, so to speak. So, I'm thinking about the fact that so many of us as providers, whether we're BHCs, medical providers, whatever that may be, are not necessarily healthy. And again, I'm just throwing this out there. How and what ways does that potentially impact upon our own willingness to talk to individuals? So that if, we know the majority of the US population trends towards being overweight, how and does that get in the way of talking about that with patients, because it may then turn the lens on our own behavior. So.
All right, we are down to 4 minutes, and I have been told that occasionally people would like to be able to get where they need to go and get to for their next get ready for their next session. So I'm going to end with a few minutes to give you the time to do that. Thank you for attending. We invite you to an upcoming June 25th 3-hour CE webinar, which is suicide assessment and empirically supported treatment options. You can learn about this at mopa.org. And also join us July 1st for our next roundtable, which will be on weight management in primary care. Have a great afternoon.
Thank you, everyone.